a professor of neuroscience and professor of neurology at the same university. He has led an epilepsy bench and clinical research project, and he's part of the teams that studies neurobiological mechanisms and circuits underlying prolonged seizures and epilepsy. He has conducted a large epilepsy clinical trials, and he receives grants from the NIH, the Epilepsy Foundation, and Cure Epilepsy Foundation. He has served as the American Epilepsy Society president in 2010. He has been on the editorial board of the journals Neurology, Annals of Neurology, and Experimental Neurology, Epilepsy Research, and he has been on multiple NIH review panels. He received the 2013 Epilepsy Research Award recognition for basic science conferred by the American Epilepsy Society, and he's the ambassador for Epilepsy Award from the International League Against Epilepsy in 2017. So, Professor Kapur, it's an honor to have you here. Uh, thank you very much for accepting this invitation.
Thank you so much for inviting me. And nice to meet you over Zoom.
Yes.
You can hear me, right?
Yes, I would like to add the learning objectives that we have for this ILAE endorsed meeting. The first one will be the 5.2.1, which is appropriately diagnose all types of convulsive status epilepticus. 3.1.1 is to identify the spectrum of action of anti-epileptic drugs and appropriately manage all types of nonconvulsive status epilepticus, including EEG monitoring and the treatment effect in status epilepticus. So thank you again, Professor Kapur.
Thank you so much for inviting me. So I want to speak about status epilepticus with you today. So the International League has defined, let me see if I can advance. The International League Against Epilepsy has revised the definition of status epilepticus, and now the definition is that it's a very prolonged seizure that either is unlikely to end without treatment. Also, it can be so prolonged that it can cause brain damage. So the older definitions of status epilepticus used to focus only on prolonged seizures, sufficiently prolonged to cause brain damage. But this newer definition focuses on a more operational definition of status epilepticus, where if seizures are very prolonged, you should treat them early. And as I talk more about status epilepticus today, I'll focus on ways to treat status epilepticus early and why is it so important to terminate seizures before it's too late. So just briefly about epidemiology, we know in US large-scale studies suggest that there is incidence of status epilepticus is about 40 to 60 per 100,000, and we have about 120 to 200,000 cases of status epilepticus in US. One thing I'll point out is that these data are based on old studies that were done in mid-90s, 1995, 1996, and they used a definition of 30 minutes of convulsive seizures as a definition of status epilepticus. Since then, as I just told you, the definition of status epilepticus has changed, and operationally, especially for convulsive seizures, we consider 5 minutes of seizures to be status epilepticus. So what we now would have taken as epidemiology of status epilepticus, there would be a lot more cases that would be present. Also, this does not include non-convulsive status epilepticus, and many patients, as you know, are being discovered to have status epilepticus when they're comatose and EEG is recorded from them. About 1 in 5 patients who has generalized convulsive status epilepticus will have to be intubated. Many of these patients who require intubation actually have respiratory compromise. So acutely, the biggest danger that there is for a patient in status epilepticus is respiratory compromise, which requires intubation. All-cause mortality, that is, underlying causes and seizures included mortality with status epilepticus in 30 days varies to about 19 to 20%. And and the mortality in status epilepticus increases as uh, as patients age. So young patients are very unlikely to die from status epilepticus, but uh, death is more common in patients who are older. So 65 and older individuals have far higher mortality rates than young individuals. During status epilepticus, there are multiple changes that occur in systemically in the brain, and these dictate the treatment and have impact on treatment. So status epilepticus should not be viewed simply as a prolonged seizure. It should be viewed as a neurological emergency where the brain is evolving and changing, and the whole body itself, its reaction to seizures is also changing uh, through the course of status epilepticus. So one of the first things during generalized convulsive status epilepticus is that uh, cardiac output, blood pressure, blood glucose, and lactate go up systemically, and the cerebral blood flow is compensating for the increased demand that seizures put on neuronal metabolism. And as time goes on, the seizures may become less dramatic, that is, convulsive seizures become non-convulsive in nature. But what changes then is that the blood flow and brain oxygenation is no longer compensating, but the brain is continuing to have seizures. And this is once these kinds of changes start occurring, that's when brain damage will occur, when even though the patient doesn't appear to be having convulsions. So, and we have evidence now that prolonged seizures can cause brain damage in individuals, and the best evidence for that comes from FEBSTAT study, febrile status epilepticus trial that Shlomo Shinar, Darrell Lewis, and many others have been carrying out for last 15 years. And what they've been looking at are children with febrile seizures, and they're comparing children with simple febrile seizures with just few seizures compared to multiple prolonged seizures lasting 30 minutes or more, often that are focal in nature. And these children undergo fairly extensive testing, both MRI, EEG, and neuropsychological testing. And they have serial MRIs in that study that follows any changes in the hippocampus. And as I'm showing you here on the right side, there's 11% of patients with complex febrile seizures develop evidence of hippocampal injury in form of T2 signal increase compared to those with simple febrile seizures where none of them do. And some of these patients have gone on to develop hippocampal sclerosis or mesial temporal sclerosis uh, after a bout of febrile status epilepticus. If you do EEGs on these patients, also you will see that there is evidence of hippocampal injury in form of slowing on EEG as recorded. So, and first question I want to address with you is what are the changes in the brain that occur during status epilepticus? So I just showed you that hippocampus is involved in status epilepticus. And if you look towards the left of the slide, in the hippocampus circuit is that CA1 neurons project to the entorhinal cortex through subiculum. Entorhinal cortex projects to dentate gyrus, and dentate gyrus then projects to CA3 and then CA1. And there is this re-entrant circuit from CA1 to dentate gyrus uh, where seizures are continuously occurring. Naturally, the dentate gyrus is a structure that is designed to limit flow of information into the hippocampus. It serves as a filter for neuronal activity, and it is strongly inhibited in normal brains. But when seizures are going on, uh, what happens is that this inhibition in dentate granule cells breaks down, and this breakdown of inhibition allows greater and greater activity to go to CA3 and CA1, and that increased activity results in status epilepticus, causing damage to CA1 region of the hippocampus, the CA1 hippocampus. The initial treatment of status epilepticus is benzodiazepines. And this has been shown by 4 different well-designed, carefully designed clinical trials. These are phase 3 clinical trials, which show that the first one is from VA cooperative study, which is on your left in the bottom. In generalized convulsive status epilepticus, patients were treated either with lorazepam or phenobarbital or diazepam and phenytoin, or uh, with phenytoin alone. And the key point from this trial is that lorazepam was superior to phenytoin for generalized convulsive status epilepticus. And this in this trial, the patients were treated in the hospital, so they were witnessed to have generalized convulsive status epilepticus in the hospital. Next trial was done in pre-hospital treatment of status epilepticus, done in San Francisco by Dan Lowenstein. And here, what they did was to change the definition of status epilepticus. They said that if a patient is found to be having seizures and rescue squad or emergency personnel arrive in at the site and their patient is still seizing, then they have they're considered to be in status epilepticus, which would meet the current definition of status epilepticus, which is 5 minutes of convulsions, because it does take 5 to 10 minutes for rescue squad or emergency medical personnel to arrive. And in this trial, again, they compared, this is the only placebo-controlled trial of generalized convulsive status epilepticus that we have. And in this trial, if you notice, lorazepam terminated, which is in red, terminated status in significantly more individuals, approximately 55% compared to placebo, which was less effective. So this led, and this is one of the trials that has led to the consideration that we should treat status epilepticus early. The next trial that again showed this and dramatically is the Rampart trial. Here they tried intramuscular midazolam versus intravenous lorazepam. And the major reason for trying this was that they want, it takes time to start an intravenous drip, and they wanted to know if they could start an intravenous, if they could give a benzodiazepine like midazolam, which can be given intramuscularly, would it be at least as good as intravenous lorazepam? And in fact, what they found was that midazolam was at least as good. In fact, it beat the non-inferiority margin, so that you can use intramuscular midazolam, which is a benzodiazepine, with great confidence that it performs at least as well as lorazepam, which tends to perform as well or if, better than diazepam. Many of these trials that I've just spoken about primarily focus on adults, and it's important, but children suffer from status epilepticus. In fact, status epilepticus is more common in children than in adults. So it's important to know whether these drugs work in children as well. And uh, in a study conducted by Jim Chamberlain in Washington, D.C., they compared lorazepam and diazepam for pediatric status epilepticus, and they were equivalent, and they were effective in about 70% of patients. So the big reason for treating this convulsive status epilepticus rapidly with benzodiazepines is that you have risk for developing respiratory arrest or requiring intubation if you don't treat it. And this was best shown by the pre-hospital treatment of status epilepticus trial conducted in San Francisco by Dan Lowenstein and others. And what they found was that the patients who did not get any treatment, got placebo treatment, had 22% intubation rate, whereas those who got benzodiazepines had an intubation rate of 10%. So that there is a risk for hypotension, cardiac arrhythmia, or respiratory intervention if you don't treat these seizures emergently. And that's why we are moving towards new definition of status epilepticus. So why does this happen? Why do benzodiazepines start failing if you delay the treatment of status epilepticus? And that is because uh, GABA receptors, which are the targets of benzodiazepines, are being internalized all the time. And seizures accelerate the internalization of GABA A receptors. And as you know, surface expression of GABA A receptors is essential for their physiological effectiveness. So uh, what we found is that prolonged seizures will cause internalization of GABA A receptors, and benzodiazepines become less and less effective in experimental animals, and even in human patients. We've seen that delaying treatment, even delay of starting an IV, made IV lorazepam somewhat worse than midazolam in the Rampart trial. Once benzodiazepines have failed, the next stage of status epilepticus is called established status epilepticus. And established status epilepticus is benzodiazepine refractory status epilepticus. As I was showing in previous set of slides, about 1/3 of patients, depending on which study you look at, 30% to 40%, will fail to respond to benzodiazepines like lorazepam or midazolam. And those patients uh, uh, need second-line therapy for treatment of status epilepticus. So for established status epilepticus, there are 3 drugs that are commonly used: fosphenytoin, levetiracetam, and valproic acid. And the most commonly used one in US has been phenytoin or fosphenytoin, followed by lev and valproic acid. There is a problem in using fosphenytoin in that it can cause cardiac arrhythmias or hypotension. Lev or valproic acid you can give very fast. Because of slow administration, there's fear that fosphenytoin will be too slow. On the other hand, levetiracetam enters the brain slowly. Valproic acid goes into the brain fast and acts fast. All of them have long-term effects and have long-lasting action, and they're all efficacious in animal models, though fosphenytoin is somewhat less effective than other drugs. And they terminate partial seizures in all cases and are known to terminate generalized seizures for valproic acid and levetiracetam. So in order to figure out what is the best or the worst treatment of established status epilepticus, So a clinical trial was conducted called Established Status Epilepticus Treatment Trial. And it was a multi-center randomized blinded comparative efficacy study of fosphenytoin, valproic acid, and levetiracetam in the emergency department for treatment of patients with benzorefractory status epilepticus. And this is a large study, actually, with planners for this study were from all over the world, from Europe. Hannah Koch and Eugen Trinka participated. A bunch of investigators from US participated. Jim Chamberlain brought expertise in pediatrics. Status epilepticus, Tom Black from Neuro ICU. Jim Cloyd did all the pharmacology for it. Nathan Fountain has worked on non-convulsive status. You've heard Dan Lowenstein has done previous trials. Shlomo Shenat, Robert Silbergleit, and David Tryman, all of them have done previous clinical trials in status epilepticus. And this trial was done with what we call exception from informed consent. Because the patient is in status, we can't get consent from the patient, we can't inform them, and even their families are so distressed that there's not enough time to conduct informed consent. So this was done under exception rules. Patients for this trial had to be having a seizure in past 5 to 30 minutes. After a witness seizure, they were treated with benzodiazepines, and if they received an adequate dose of benzodiazepines and continued to have seizures 5 minutes after the last dose, then they were eligible for this trial. We excluded children below 2 because some people were concerned that febrile seizures may contaminate this. Other concern was that valproic acid maybe have toxicity in children under the age of 2. What we did in this trial was to give either 20 milligrams per kilogram of fosphenytoin with a maximum of 1,500 milligrams, or 40 milligrams per kilogram of valproic acid with a maximum of 3 grams, or 60 milligrams per kilogram of levetiracetam with a maximum of 4.5 grams. And the maximum was reached at 75 kg body weight. So up to 75 kg, patients received a dosage based on body weight, and after that, they received dosage based on a fixed dose, as I just pointed out. And so this is the layout of the trial. Patient is seen having seizures. The emergency medical personnel bring them to the emergency department. They receive benzodiazepines before or during their arrival in the emergency department. They again tested whether they're having more convulsive seizures, and then they were given this drug over 10 minutes, one of the 3 study drugs, and then the outcome was determined by clinical examination of the patient. So clinical cessation of status epilepticus determined by, so basically the patient was examined, and if they had stopped having convulsions and they were trying to wake up, they were considered to have been treated for status epilepticus. So if patient was intubated, they were considered to have been have failed the drug. Also, if they didn't wake up, even though there were no visible convulsions, they were considered failures. This is because we didn't have any EEG to determine the outcome. So this is one of the shortcomings of the study, that we did not have any EEG to determine the outcome. It was determined entirely on clinical grounds, but in most places in the world, this state of status epilepticus, you will determine outcome of treatment clinically. So we had 400 patients, 384 were unique, some were re-enrolled, and we, as you can see, we had somewhat different number of patients for each drug. This is because this was the trial design was Bayesian. That is, the more patients were allocated to drug that appeared to be doing better, though. So levetiracetam appeared to be doing better, so more patients got allocated to that compared to fosphenytoin and valproic acid. If you can look at by age, those mean age of individuals getting these drugs were the same. You can break down the age from 0 to 5 and 5 to 10 and so on. And as you can see, mostly the age, the number of patients in each age group getting those three drugs were similar. The key result of this trial is summarized in this figure. The response to levetiracetam was 47%, response to fosphenytoin was 45%, and valproate was 46%. So there was essentially no difference in clinically apparent seizures or improved responsiveness. Approximately half of all patients responded to these any of these drugs. And also, in this primary analysis, there was no significant difference in safety. And I'll get into safety a little bit more. So this is graphical representation of data from the last chart. The probability that one drug is better than the other is shown in the probability density function on top. And as you can see, that there was no difference between the three drugs. We can do an intent to treat analysis, per protocol analysis, or adjudicated analysis. Adjudicated analysis is where two neurologists went over the chart and determined the outcome independent of the treating physician. And all three analyses revealed essentially the same thing, that all three drugs were equally effective in treatment of status epilepticus. As we were analyzing the results of the primary study, it became apparent that in kids, one of the drugs appeared to be doing a bit better than others. As you can see in the primary outcome drugs A, B, and C at middle of the chart in pediatric status, 55% effectiveness for one drug and 47 and 47 for the other one. This made us continue recruitment of children, and we recruited a total of 225 children for the study, and then were able to separate out age-wise effect of status epilepticus. And this age-based outcome is published in Lancet earlier this year. And as you can see, after adding children, the response rate to three drugs was exactly the same in children. Younger adults are from 18 to 65, and older adults, which are 65 and older. But one thing surprising came out in analysis of children, and which is shown in here, which is in safety outcomes. If you look at safety outcomes and endotracheal intubation in children, fosphenytoin had a much higher rate of, and it's 3 times higher than other two drugs. So children who were treated with fosphenytoin were 3 times as likely to get intubated than other drugs. And this was statistically significant. So we don't know why this happened. This may have been a side effect that more kids in certain sites got fosphenytoin, because fosphenytoin is not known to cause respiratory depression. And as you can see, the respiratory depression rate was no different. Also, interestingly, there was no difference in life-threatening hypotension and cardiac arrhythmia, which is a feared complication of fosphenytoin. We didn't find that in adults, young adults, or even in older adults. So even though neurologists are worried about hypertension and cardiac arrhythmia in due to fosphenytoin or phenytoin, we didn't find those two to occur. So other than intubation rates in children, there were no safety signals found between these three drugs. So in summary, we demonstrated that approximately 50% of patients with established status epilepticus respond to anti-seizure drugs and wake up. Obviously, we would like to do better. We would like to treat terminate seizures in 70 to 80% of these patients. And what we are planning to do is to do another clinical trial to see how we can achieve that. And the approach to the next trial is that what we did in the ESET trial was to use drugs that are anti-seizure drugs. And now we want to use drugs that stop plasticity of brain that occurs due to seizures. And there's a lot of research, bench research, that suggests that NMDA receptor activation occurs during status epilepticus. I've shown two figures here at the bottom, where if you take NMDA receptor antagonists, seizures get worse and worse as you repeat them, kindling-like phenomenon. But if you add in NMDA antagonist, the seizures stop getting worse. The seizures don't stop, but the worsening is stopped by an NMDA antagonist. And we know that ketamine is an NMDA antagonist. So next trial, what we are planning to do is to study the role of if we can terminate status epilepticus using ketamine. NMDA receptor activation has two effects in the brain that mediate plasticity. One is that it enhances AMPA-mediated transmission, shown on the left. And second is that it reduces GABAergic inhibition. And this is shown on the right, and both those effects would be blocked if we blocked NMDA receptors. So that's why we are interested in studying these. After second line agents fail, you'll need to do EEG, because patients often become comatose, as I just referred to. They're not responsive, and these patients need to have an EEG to diagnose status epilepticus. These patients, plus those who have intracranial hemorrhage, CNS infections, brain tumor, severe head trauma, or subarachnoid hemorrhage, are likely to be having seizures that are not clinically recognized, are only recognized on EEG. And again, these patients are in refractory and super refractory status epilepticus. And most often the cause of these refractory and super refractory status epilepticus is acute brain injury rather than chronic epilepsy, and inflammation, stroke, and hypoxic injury to the brain is commonly found. And within inflammation, there are two common causes of inflammation. It's about 6% of all adult patients, but either you can have infections causing inflammation of the brain and then causing status epilepticus, or it could be autoimmune etiology, which causes status epilepticus. So if you have a patient who's having prolonged refractory status epilepticus, then treatment with, before we start treating, it's important to check for antibodies against NMDA receptors, voltage-gated potassium channels, LG1, GAD, etc. And obviously, there are well-defined syndromes that occur due to antibodies against NMDA receptors and potassium channels and LG1 complex. And it is important to clinically recognize these syndromes and treat. The common way in which we treat refractory status epilepticus is either with midazolam drip or propofol drip. And in this slide, we've just given the loading dose of midazolam and then maintenance dose. Challenge when you use midazolam is that patients increasingly become refractory, and you need higher and higher doses of midazolam as time goes by. With propofol, which is a very effective anesthetic, there is always a fear of propofol syndrome, which where patients can develop complications from propofol itself. In certain areas of the world, barbiturates, thiopental, and pentobarbital are used for treatment of refractory and super refractory status epilepticus. Again, there are no good clinical trials that tell us what is the best treatment. There's also debates and controversies around using these agents for treatment of status epilepticus. These include whether you should just terminate seizures or should you then go to a burst suppression pattern on EEG. Some authors have argued that just seizure suppression is enough, while others have said that burst suppression is necessary to terminate status epilepticus. There's no good data comparing two methods. There are no controlled trials to compare it. Furthermore, there is growing concern about risk of prolonged anesthesia. Risk of prolonged anesthesia is well known, but it has come under scrutiny recently in context of status epilepticus and refractory status epilepticus. The question is whether prolonged immobility that anesthetic use causes immunosuppression, exposure to intensive care environment, does it make patient's prognosis worse, even though you're controlling seizures, you're controlling status epilepticus, but other comorbidities like infections or immune suppression, are they making the situation worse or better? And there have been two separate retrospective analyses of case series of patients who've been treated with anesthetics, and their outcome appeared to be worse than those treated with anticonvulsants, conventional anticonvulsants, such as topiramate or levetiracetam, et cetera, et cetera. And these studies obviously can be criticized because some people believe that patients may have been, there may have been a patient selection bias, and patients may have been ones with who were treated with traditional anticonvulsants were less sick than those treated with anesthetics. But at least the status epilepticus severity scales, etc., were matched in these two groups. So it's important to consider whether what's the best treatment, whether to use prolonged anesthesia or not. After one or two rounds of anesthetics fail, this is considered super refractory status epilepticus, and there are no treatments. Many things have been tried. They range from ketogenic diet, ketamine, NMDA receptor antagonist, vagal nerve stimulation, transcranial stimulation, hypothermia, all these things, lidocaine, verapamil, magnesium, immunomodulation, have all been tried. In Europe, I've read some recent studies where they've tried isoflurane or desflurane. So, and of course, I mentioned ketamine has been tried for super refractory status epilepticus. There is again no consensus and no clear good studies to guide our treatment of super refractory status. So let me just end by stating key messages of my talk, which is generalized convulsive status epilepticus is a medical emergency because it can cause respiratory and cardiovascular compromise. Treatment delay can worsen response to benzodiazepines. So early treatment with benzodiazepines is critical. Levetiracetam, fosphenytoin, and valproic acid are equally effective and safe for treatment of benzodiazepine refractory established status epilepticus. And we still need better treatments for established refractory and super refractory status epilepticus. I'll stop there and I can answer any questions.
So thank you very much, Professor Kapur, for this amazing presentation of the ESET trial. There are a few questions. The first ones are related to medications. They're asking, what dosage do you use or recommend of ketamine in refractory status epilepticus? And the other one related to this mechanism of action is related to what do you think the perampanel in status epilepticus regarding its mechanism of action on NMDA
So
receptor?
uh, for doses of ketamine, and there is a tremendous amount of uncertainty about the dose of ketamine. For our clinical trial, we're going to try two different doses, loading doses of ketamine. One, we'll try loading dose of 1 milligram per kilogram. The second dose we'll try is 3 milligram per kilogram, but that is for just established status epilepticus. And the treatment in terms of drip, most people, because in refractory, super refractory status, most people dial up the drip for ketamine using EEG as a marker to see whether seizures go away or not, and they keep increasing the dose of ketamine. It's fairly safe, so pretty high doses have been used by intensivists, but there is no consensus as to what uh, is the correct dose. But in refractory and super refractory status, when you have EEG to guide you, the dose is driven by the EEG finding and seizure suppression. So second question, perampanel, is a very interesting and important question. Yes, and I would have shown you more data on perampanel. We've done some work, and over last decade in my lab, perampanel is very effective in animal models of refractory status epilepticus. It will terminate status epilepticus, which is not responding to benzodiazepines in experimental animals. And many labs, at least 4 or 5 labs that I know of around the world, have found perampanel or other AMPA receptor antagonists. So perampanel is an AMPA receptor antagonist, and I showed you one slide, which I went over pretty quickly. Here, this slide. So what happens during status epilepticus is that there is enhanced AMPA receptor transmission. And if you, and since perampanel works on AMPA receptors, it will terminate benzodiazepine refractory status epilepticus, we anticipate. And I think they are planning a clinical trial of perampanel for refractory status epilepticus, the company that owns it. I had heard that they were planning one. I do not know if it has started yet.
Okay. Do you think there is a role for corticosteroids on treatment of status epilepticus regarding these inflammatory mechanisms and pathways?
Yes. So for inflammation, so as I mentioned, in many of the patients who have refractory and super refractory status epilepticus have evidence of inflammation. Often this inflammation is due to autoimmune etiology. Now, there is no consensus as to what is the best treatment for autoimmune uh, status epilepticus. Some centers in US use plasmapheresis, while others use immunosuppressants. And as you know, uh, steroids are immune suppressants, and there are case reports and case studies of using steroids for status epilepticus. Of course, you have to be very sure that that status epilepticus is not due to any infection, because it could make it worse.
Definitely. There's another question regarding lacosamide. Do you think lacosamide could be effective in the treatment as a second-line agent?
Lacosamide, so there is a clinical trial that Atif Hussain ran for refractory status epilepticus. He compared lacosamide to phenytoin, and the results showed that they were about similar. So lacosamide has probably the same efficacy as phenytoin or fosphenytoin or levetiracetam or valproic acid for status epilepticus. It's about equivalent to these drugs. My guess, that's my best guess.
Okay. Do you think there are any recommendations regarding focal status epilepticus with preserved awareness? And if so, if there's a place for anesthetic therapy on treating that?
Increasingly, my view has been, and this is just my opinion, so that it is not safe to use anesthetics for just focal status epilepticus if you can get away treating with traditional anticonvulsants. There's not good clinical data, but I worry that prolonged anesthesia for a focal seizures is more dangerous than the disease itself. But again, we don't have much data. But I tend to avoid using anesthetics for focal status, especially if consciousness is preserved or seizures are intermittent focal on EEG.
Okay. And the last question is, do you think the pediatricians have a lower threshold for intubating patients? And maybe that's why they have higher rates on intubated patients?
Actually, the intubation rate in children in our study was 1/3 than adults. So we found the opposite of the question. We found that pediatricians don't like to intubate children. So the intubation rate in children was 8 to 10%, but in adults it was 25 to 30% in our study. So that's what we find. But I agree with that question that there is a lot of variability from site to site. Some physicians will intubate patients early, even for kids, while others, like in our study, if you went to an emergency department in Houston, you had low likelihood of being intubated for a child. If the same child went to a emergency department in Atlanta, they had 3 times as much likelihood of being intubated. We're going to publish that paper soon. It's almost ready for publication. So I agree with your point that some clinicians like to intubate more than others.
Okay. So, Professor Kapur, I think there is no more questions. Thank you again very much for this amazing presentation.
Thank you. Thank you so much for inviting me.
And probably we're anxious to see your next publications on status epilepticus. Thank you very much.
Thank you. Thanks again.
Salut.